I'm Prasanna Krishnasamy. I'm the Medical Director of Clinical Ethics at Legacy Health. I have the pleasure of introducing the panelists for our next session, titled Nowhere to Go, Ethical Issues with Boarding in the ED. We have Dr. Melissa Denny, who's an emergency medicine physician at Kaiser, and she's also the Medical Director of Clinical Ethics there. We have Kevin Bibee, who's a social worker by background, and he's the Supervisor of Social Work at OHSU. And then we have Dr. Lasky, who's a pediatric rheumatologist by background, and he's the lead of the maternal, fetal, and pediatric and adolescent ethics consult service at Legacy Health. We are going to have the panelists speak, and we'll have about 15 to 20 minutes for Q&A. And then we're going to have breakout sessions where Melissa and Drew are going to be talking further about their topic. And from the conversations we had over wine yesterday, it appeared like Melissa and Drew have cracked the solution for this complex problem.
Wow.
So with that, I will leave it to you guys. Thank you.
Hello, everyone. Thank you, Prasanna. My name is Melissa Denny. Like you said, I'm an ER physician for the last 10 years practicing at Kaiser, prior to that practicing in Arizona at Banner Health Systems, if you're familiar with those. I want to borrow Cinda's words and thank you for this opportunity to speak out against something that I find morally challenging. So the agenda today, I'll briefly talk about what is ED boarding, talk about the unique situation in Oregon, and offer several ED physician perspectives. And then we'll just touch on ethical considerations, and I'll go in those into more depth in the breakout session. So what is ED boarding? So this is after somebody has already gone through the waiting to see the nurse in triage, the waiting to see the physician, the waiting for test results, the waiting for the follow-up discussion with the ED physician or nurse practitioner or PA to tell them what's going on, what are the next steps. And the ED provider has determined that they are not safe to be discharged. They need mental health stabilization, maybe addiction medicine treatment, maybe they're an elderly person waiting for SNF, skilled nursing facility placement, or other type of higher level of care, or maybe they need admission to the hospital. But there's nowhere for these patients to go right now, so they are boarding in the ER. There's no hospital bed available, the hospital is full, there's no SNF facility that can take them, there's no ICU bed, so they are in limbo. They are boarding in the emergency department. What's happening in Oregon? So this is an OPB article from 2022. Oregon's hospitals are close to running out of beds, and a backlog of patients waiting to move into the state's understaffed long-term care facilities is making the problem worse. They may need a nursing home, a rehab bed, behavioral health support, or they may not even have a home to go to, quoting Becky Hutbird, president of the Oregon Association of Hospitals and Health Systems. Roughly 10% of all hospital beds statewide at that time were being occupied by patients ready for discharge with nowhere to go. Discharge delays are a long-standing issue, first described in the 1990s. There's papers going back in the 2000s on identifying the problem of ED boarding, but the COVID pandemic made it drastically worse, and unfortunately things have not gotten better. So ED care is common, right? 1 in 4 Oregonians seek ED care annually. So on average, a quarter of the people in this room or a quarter of the people you know will have sought care in the ED. So this affects a large portion of our population. 1.3 to 1.6 million ED visits in Oregon each year. Notably, 75,000 patients who check into the ER thinking they need emergency care leave without being seen. And that number rises with the rise in wait times, with the percentage of ED boarders occupying the ER. More information on ED boarding. Bear with me on these statistics. I just want to give you an idea of the scope of this issue. In the past year, almost 47,000 Oregonians were in an ED for at least 24 hours. Almost 8,000 were in the ED for at least 72 hours. Vulnerable patients are much more likely to board for days. If you're experiencing homelessness, you're 2.3 times more likely. Mental health patients, 4.4 times. If you're an elderly patient, you are 2.8 times more likely to board in the ER. Talk about justice, equity. Oregon and Washington have the lowest hospital beds per capita in the United States. We are those bottom lines. Oregon with 1.65 hospital beds per 1,000 people, compared to the United States average of 2.35. So this is an especially challenging situation in Oregon. The impact of ED boarding. So when a hospital has enough beds, right, but we already established that Oregon is lacking enough beds to care for its population. There's few boarders, and admitted patients can go upstairs quickly, and there's room for the waiting room patients to be seen in the emergency department. On the opposite side in red, when the hospital's full, which so many of our shops often are, you get patients admitted boarding in the ER for an extended period of time. It leaves few beds to actually see the acute stroke, the acute STEMI, the trauma patient, very few beds to see the critically ill patient. The waiting room becomes full, unsafe, and violence prone. What's the ED physician perspective? What's it like to work in this environment? The impact of ED crowding on morbidity, mortality, medical error, staff burnout, and excessive cost is well documented for decades, but remains largely underappreciated. A lot of the ED perspective from the physicians I know is that we feel unseen, that we feel like this is a well-documented problem, we see it every day, and we feel unseen. This article highlights emergency department crowding, the canary in the healthcare system. The ED boarding is not a function of the ER, it's a function of the output from the ER. The ER has finished the workup, and now these patients have nowhere to go. So the ED physician can't make more SNF beds, can't make more medical beds upstairs, but we are looked at as to find the solution to the problem. And that causes moral distress. So ACEP, the American College of Emergency Physicians, recognizes us, they see us, our organizations see us. They allow physicians to share their stories about ED boarding on their website and post them. This is open to the public, so you can click through story after heartbreaking story. I will read one called In the Waiting Room. We are a 28-bed ED and on a daily basis have 60 plus patients in our department while consistently boarding around 20, so 8 functional beds for their 60 patients. Wait times and the percentage of people leaving without being seen began to climb, so as a result, we have been forced to see patients from the waiting room. I can't remember the last time I got to consistently see and examine patients appropriately in a room bed and not from a chair. I've seen people code in the waiting room and admitted patients to the ICU from the waiting room. It's unsafe for patients and frankly unsafe for us to have to go into the waiting room dozens of times per shift. This ED physician's not alone. We treat patients now from the ER, from hall beds, from chairs, from all types of situations. And we're not alone. This has happening across the country. More stories, I'm just gonna read the highlights here. An afterthought. How did we go from being healthcare heroes to an afterthought of the medical system? Acts of bravery. Each day, I fear that a patient or staff member will be harmed because of the critical situation in which we are required to serve. This is a study published in June 2024 from the Annals of Emergency Medicine that took comments from emergency physicians. I'm going to read 2 of them. It is morally distressing to watch elderly patients dropped off at the emergency room with nowhere else to go, languish in our corridors, end up sicker than when they arrived as they wait for placement, and in some cases die from neglect. We are asleep at the wheel, and we are headed for a crash. I'll read the bottom right. I still love the essence of emergency medicine. Caring for patients and having the privilege of making their scary, horrible day a little bit better. The environment is drowning me slowly, and it's increasingly difficult to come up for air. After 23 years in the ED, I don't think I'll last another year. I'm done. So these are really heartbreaking sentiments, and they really ring true to my friends in emergency medicine. Many have left. I just had one friend leave not very many years out of residency because he felt so threatened at work. Couldn't do it anymore. Ethical considerations. I think we probably all have an idea of what's going on. This is from 2010. Remember, this problem has been worsening for 30 years. So this is from Dr. Arthur Kellerman in the Medical Ethics Advisor. The practice is unethical for several reasons, he writes. The first is that ED boarding is associated with poor outcomes and higher numbers of medical errors. It is also unethical because boarding is a major cause of ED crowding, which in and of itself can be hazardous. As the number of boarders increases, the effective capacity, as we saw, of the ED is reduced, which increases waits. It increases left without being seen. So there are fewer active treatment spaces for the new undifferentiated cases. So permitting boards is a violation of beneficence because it is not in the best interest of the patient being boarded, but also not in the best interest of the new undifferentiated patient in the waiting room. Both can experience negative outcomes from this practice. Thank you for your time. Thank you for seeing me and hearing our situation. In my breakout session, I'll talk more. I'm going to pass it off.
Hello, everyone. Like Prasanna said, my name is Bibee. I'm the social work supervisor in the emergency department at OHSU, and I've been doing that for about 2 years, and it's been a great experience. And then before that, I was at Providence for 7, 8 years in different care management roles, including working on one of the psych units that they have. And so I'm going to talk a little bit more about moral distress and safe discharges. One of the things I kind of think the role of social work is to kind of tell patient stories. And so I'm going to hopefully kind of highlight a lot of the stuff that Dr. Denny was saying through a case example that we had recently. And then I'm going to kind of move on to talk a little bit more about moral distress and kind of what that looks like. And then also in the social work setting, a lot of what we are working on is discharging folks without like that's why I put air quotes over safe discharges. Like, what does it actually look? Is it safe to discharge somebody to the street in any circumstance? Right? So we're going to talk about that a little bit as well. So the case I'm going to talk about is Roxanne. I changed some of this information to protect her privacy. But as you can see, she's a 51-year-old cisgendered female. She had at least a 4-year history of houselessness. She has basically all the things, both physical and mental disabilities. She has a substance use disorder. She has a severe and persistent mental illness that included psychosis as one of the symptoms. Luckily, the state has actually done a lot of work on expanding the public guardian system here, and she was actually able to get a public guardian recently, and then she ended up getting placed in a facility. Unfortunately, the facility did not do a particularly thorough job when they looked at kind of what her symptoms were and how she would fit into the milieu. So she was there for about 3 weeks when she was discharged to the hospital, to OHSU, with kind of the hopes of finding a medical etiology for what she was going through. It took about 24 hours. They ruled out all the things. It was not medical. It was a behavioral and psychiatric issue. Unfortunately, her guardian did not sign the paperwork that she needed to have her return to the facility that she came from, so they immediately gave away her bed. And I called over there. I did advocacy. That's why they actually ended up pulling in a supervisor. I don't actually do a lot of patient care these days. And when I talked to them, like, I really understood where they were coming from. So she would make racist comments to staff. She would yell out in the middle of the night. A lot of the folks there were also struggling with all kinds of illness, mental or otherwise. And she would, they told me about like 2 o'clock in the morning, she's yelling racist slurs. Everybody's waking up. It's just an awful situation. She also really does have very little patience, very little frustration tolerance. So she literally had nowhere to go. So she ended up boarding in one of our psych rooms. And if you're unfamiliar, it's like this big and there's nothing in there. They did move a hospital bed in there, and there's a camera in the corner. There's a big thick door that looks like the door that you would imagine on like a jail cell with a tiny window that looks into a hallway, and that's it. And so she's in this room, nowhere to go. She was pretty articulate in like saying, I'm here for a UTI, I shouldn't be in a psych room, right? It wasn't actually a UTI, but that's how she kind of perceived it. And when I kind of talked with my staff about this case and kind of what the moral distress aspects were, one of the things they immediately identified was that the system was treating her subhuman. And so I actually kind of thought about that a little bit as her, like many racist statements, her violence, is that she's also then expressing that externally. She's treating other people like they're less than human, and we're treating her like she's less than human. And that just kind of is a perpetual system that really just gets at a lot of where the moral distress comes from. Another thing I actually was just thinking about when Dr. Rushton was talking was the conflict that a lot of folks feel when two areas that we all really, or more, care about don't mesh well. They come in conflict. So, for example, is it, I'm a strong advocate that we should care for patients. We should care for all patients. And when these patients are making the work environment hostile for staff, I also care about that. And OHSU, to their credit, has really done a lot of work making the institution as welcoming for people of all backgrounds as they can. And to their credit, they seem to be sticking to that even in current climate. But when we have a patient that is sort of working against that, it really does make it difficult on kind of when we're looking at the micro versus the macro and how they're coming in conflict. She was also dependent on all of her ADLs, so she required a lot of care. And she was really, even when I went and talked to her, I stepped out of the room to kind of debrief the case with the nurse, and she was just like, Kevin. And I was like, I only had to see her for like a few times over a few days, and even I was like, oh boy. So I made a joke about how I was getting paged, and I went back and I talked to her, and she asked me to do a bunch of stuff that I actually were outside my scope. But I think that that's kind of a good example of how things just really, just that conflict of where the healthcare system as a system, its ability to care for individuals, but also care for the people caring for them. And when ED boarding happens, that conflict, if it hasn't already started, naturally starts at the point that they start boarding. That's not what the patient wants. They don't want to be stuck in an ED, and it's not what the staff signed on for. It's not what they're looking forward to. It's not how they practice the best medicine. So then what do we do, right? And so a lot of the social work role is setting up a safe discharge. That was actually one of the things that a previous supervisor of mine, Sarah Power, said was discharge to prior living situation. That's often the best that we can do for folks. So if somebody comes in and they are unhoused, 99% of the time they're leaving unhoused, which is, we know is going to continue to cause more problems for folks. Is it ever safe to discharge somebody with a tent and a sleeping bag? I mean, that's often our best option. Or is a shelter bed any safer than that? Often people are assaulted in shelters. If you have anything that's in a prescription bottle, you're a target. the aspects of violence towards women, violence towards transgender people, it's really pretty distressing. So if somebody says, I'd rather be in a tent than a shelter, it's like, I'm not going to fault you for that decision. That's right for you right now. We have one program in Portland for medical respite, so folks that have an acute medical need that could resolve in 2 to 6 weeks, but are independent in all their ADLs or modified independent, the recuperative care program. We were talking about if we had like money, like where would we give it? I'd give it to this program. Central City Concern needs more money and they need to expand. But it's a temporary solution to a bigger problem. And so that's, best case scenario, we get somebody into there. But they're also, often that's a 3-day referral process. And then, so for mental health, and this kind of applies back to Roxanne, is that her guardian was actually working on getting her set up with a long-term treatment program. And that's probably what would work out best for her, is to kind of address some of these bigger needs while she's in a stable situation. But it was too slow, it took too long. She actually hadn't been in that facility for very long, and if we look at Maslow's hierarchy of needs, if we don't get somebody's basic need of like shelter met, we can't really expect them to start working on their mental health. So we got her in some place where her shelter needs were met, but she didn't last because of her symptoms from the mental health. So, that's kind of what I think is a good example in how this actually impacts people in many different ways. It's not good for our patients, it's not good for our staff. There's a conflict between all of the different things that we want to work on, all of the different ethical considerations that we have and we care about. Nobody got into this profession to, do harm. We want to help people, and then often the resources, the systems just make it really, really challenging. I definitely resonated with whoever said like budget and then making money we're in budget season. That's been something that I've been thinking about a lot. So thank you. I hope this was helpful and that Roxanne's story can kind of humanize a little bit. Like these really, like the statistics are really helpful on a macro level, but this is also impacting people day to day. Thanks.
Which button? Green. That one, the big green one?
Yeah, the big green one.
Okay, cool. Looks like the slides are working. I really appreciate everyone being here and being invited to talk. My name's Drew Lasky. I'm a pediatric rheumatologist by day. By night, I do pediatric ethics consultation. I'm lucky enough to do that for Legacy Health, and did that previously in Kansas City, Missouri at Children's Mercy Hospital. I wanted to give a little bit of perspective about ED boarding from the adult to the pediatric world. I think that everyone isn't familiar necessarily with the job of the people in the emergency department. Patients come in and they're looking for help, and they have things they have to do. Every patient comes in and they go through this process, right? The patient gets assessed, they get stabilized or evaluated in, with interventions to be able to get them to a certain place. They're going to determine the disposition and what can happen. Do they need more support and care and get admitted, or can they go home, right? Every patient comes in, this is the process. And in the end, they either get admitted to the hospital or they get discharged home or to whatever their setting was. Unless, of course, the system isn't quite working, right? There's some different definitions about ED boarding, and I really like Melissa's the most, but a few of them is the practice of caring for admitted patients in the ED after hospital admission, or the practice of holding admitted patients in the ED or other non-inpatient areas because the inpatient beds are not immediately available, or the ED provider has seen a patient and determined it is not safe to be discharged, and they have nowhere else to go right now. And that right now is a really big issue, because that right now might be an hour, right? It could be half a day. It could be 3 days. It could be 7 days. It could be 30 days. And if you can't believe it, patients are housed in emergency departments for weeks and weeks on end. And as everyone's thinking, that can't be good. Can't be good for the patient, the providers, for everyone else, right? I stole this slide from you, Melissa, by the way, but this basically breaks down who are the patients who are being boarded in the emergency departments. They may have mental health issues, addiction issues, elderly looking for placement issues, or patients who need to be admitted. That's in the adult world. Pediatrics is a little more simple. Okay, simple may not be the right word, but a little less diverse. You have patients who have mental health issues. Those patients are looking to be transferred to an inpatient psych ward somewhere. You might put behavioral health along with mental health issues, except it's a little different because those patients do not need a psychiatric bed. They don't have acute psychiatric issues, and therefore the goals of their treatment is going to be different, or their goals of placement are going to be different. These patients are frequently have developmental delay, which add to their behavioral issues. And again, they're waiting for a safe placement with respect to their disposition. And then you have those patients who need to be admitted, and they're either going to be admitted to the floor or to the pediatric ICU setting, and they're just not beds available. In the world of moving patients out of the emergency department and structure, we understand bed availability in the facility much better and have more control over those with respects to psychiatric bed availability or helping people with dispositions in which going back to where they came may not work. This is a list of the inpatient hospital behavioral health units in Oregon. Good, that can be seen pretty well there. So this is the total number of beds, except not including those at the state-owned psychiatric hospital beds. And you can see that there are a total of 44 for pediatric and adolescent patients in the state of Oregon, right? And I think this next slide added things up, so I didn't have to go through it on the other slide, right? So you have about 429 adult beds, 44 pediatric beds. So this is the total that's available. And imagine that in the emergency departments, patients are waiting to be able to get acute psychiatric care, and how long it might take because those beds are taken, the patients who are taking them have acute problems, and there's no way to know how long it's going to take for those patients to get better and get discharged. And of course, when they get discharged, they have to have a good discharge place to go, and so they may be ready to go but not have a place to go while someone's sitting in the emergency department waiting for that bed. In the meantime, the providers in the emergency department are trying to manage these patients, right? Giving them as much help as they can, understanding that who they are and what they do is to see a patient, evaluate a patient, stabilize that patient, and have the patient leave the emergency department. And I've always said that the person doesn't choose the profession chooses the person. So think about the personalities of people who work in emergency departments, right? Who are those people and what satisfies them? What are they there to do? Are they able to achieve that? And what does it mean to have somebody boarded in the emergency department for telling them who they are and what they do and how well are they doing it? I'm going to give you a little case. Hey, Prasanna, how much time do I have? 5 minutes. Got it. Thanks. So, John, not his real name. This is a case we're going to talk more about at our breakout session, but he's a 13-year-old who's autistic, has ADHD and oppositional defiance disorder. He presents to the ED after making threats of violence to his mom after removal of the patient's computer access. I think we all can relate to that, right? Okay. Parents So the patient has a history of aggressive behavior starting around age 8, in which he bit his mother. He's recently had a 19-day stay at the Legacy Salmon Creek Emergency Department, had resources that were obtained through the state of Washington because they live on the Washington side, hopefully helping be able to make a safe discharge back home. Went back home, was aggressive to his mom that day, to then be taken to the Randall Children's Hospital Emergency Department same day. 19 days as boarding, and then comes back to Randall to a situation that trying to find a solution for him, right? Okay. Mom obviously felt threatened, did not feel it was safe for him to be at home, therefore staying at home wasn't available, so he's in the Randall Emergency Department. And this next slide is going to talk about the barriers, all of the issues in terms of what needs to be fixed to try to help John stop being boarded in the emergency department. This information came from the psychiatric note 8 days into John's hospitalization, with help of social work working tirelessly to understand all of these variations and barriers with respects to him being able to not be boarded anymore. So obviously being at home, not available, does not currently meet criteria for psychiatric care, so going to a psychiatric bed doesn't work. Respite care wasn't available. The state hospital system wasn't currently available, but there might be a 30 to 90 day wait, right? Not exactly a great option. Shelter placement was refused because of previous threats to other people, so he wasn't a candidate. The maternal grandmother refused for him to be in her house. Foster care is really interesting, in which Child Protective Services in Washington frames the idea of a patient being in an emergency department as not being abandoned. So there's no neglect. So why do we have to get involved, right? Different, the people on the Oregon side view that differently. The laws are the same, but the way that the system views it has something to do with whether they'll get involved or how quickly they'll get involved. Police engagement, kind of funny. The police wouldn't get involved because the patient's residency is on the Washington side, not the Oregon side, not that police need to get involved. And then legal, petitioning for a private dependency was filed in the court hearings to be able to try to get someone to help advocate for him. Takes a while to do. And then finally, discharging to the streets, which is obviously not ideal, but you also have to have parental permission to be able to do that, not that anyone would do that. So if you can understand day to day people trying to find a place for John to go and not being able to, obviously hard for him. We heard a little bit about what it is to be boarded in an ED, and I'll talk a little bit more about that in our breakout, but also the idea of what it does to staff, who they are, what does it mean to not accomplish and be stymied in what it is we're trying to do, which is help people.
So thank you, everyone. We have some time for questions. I can pass around the mic if people want to ask questions. We got mics.
So this is maybe for Melissa. Actually, it could be for anybody. I wonder if, for people who haven't seen it, and I know you said you'll talk about this in your breakout a little bit, but can you describe the kinds of concrete harms that happens to patients in the emergency room when they're boarded in that setting that's not meant for long-term care?
Yeah, thanks, Lori. I'll go through the data and literature in the breakout session but there are significant harms to patients, specifically with the elderly population. If you are in a hallway or a room and there's no natural light, no clock, your risk for delirium greatly increases. Approximately every 4 hours you board as an elderly patient in the emergency department, your 30-day mortality increases by 6%. So there's risk of delirium, there's increased in-hospital mortality, there's the physical complications of not having adequate staff to take care of these patients that are no longer acute emergent patients. So you imagine the staff's choice to care for the trauma coming in or the heart attack, or get the elderly person up out of bed and walk them once a day. And so people get bed sores, people get deconditioned, people don't get their regular medications. So there's significant harms to the patients and moral distress to the staff because they don't want that for the patient. They want that patient to have care, right? That's not, we signed up to care for people. So it's very challenging, and there are real harms to patients who are boarding, and then to the patients who wait, right? You have a delay in diagnosis, you come in with your abdominal pain, and there's a 4-hour delay to be seen, there's a 3-hour delay to your CT, and then by the time you get your CT, your appendix is ruptured. You know, there's real harms to the patient's care who's delayed and to the boarding patients. It's just a glimpse. Thanks, Lori, for that question.
This one might also, maybe like a trigger warning. We've been doing a lot of meetings at OHSU around like, basically how to reduce boarding with no additional resources, which is always sort of an interesting conversation. But one of the things the medical director actually brought up was there's a patient recently that had a rape kit done in an elevator. So that's like the psychological harm of that, I think, is also pretty important to call out.
First of all, thank you so much for what you do every single day. When I was at OHSU, we had a Schwartz rounds that was specifically around the issue of boarding in the ED, and I remember so vividly the distress that was expressed by the ED staff, and as you said, Dr. Denny, the feeling not seen and also feeling blamed, for a situation that was untenable. Do you have any thoughts about how we take care of the ED staff?
We bring Cindy in, and she talks to all of us and help us recognize our strength and that we're on the ship together and we got to steer the boat, and we have to choose our attitude in the space. I think that's helpful. Caring for the staff, it's really challenging. There's a lot of staff turnover right now, a lot of people leaving the emergency department world for other positions in healthcare or leaving healthcare altogether. So I think finding a way to take care of the staff is critical. I let the staff know that I speak up for them. I have been speaking up about this with the support of my boss for the past 4 years, speaking to senior leadership, and we are making changes in our emergency department to better care for ED boarders, which helps, I think, at least helping them feel heard and seen. Thank you for the question.
Yeah, it's a good question, and it's not an easy answer because none of them are they? For my next talk, I went back. I was involved a little in the consult for that patient initially, and then I went back 8 months later and I re-interviewed some of the stakeholders. It becomes clear that communication about decisions are not well communicated from top down. So at a senior level, decisions are being made about who goes to a psychiatric bed or not, or who gets admitted to the floor, who continues it for ED boarding. And there's lots of good reasons for those decisions to be made, but there's a lot of people who are in the ED, nursing, caretakers, physicians, and even some of the physicians are not understanding how those decisions are made. Also, think about the hospitalists on the floor who may have a patient with a admission waiting for placement somewhere else, who's very similar to the last one who was ED boarded for a week, but this one goes to the floor. And the difference in those decisions and subtleties are not discussed. Finally, I have some ideas with respects to how do we improve communication. What role might ethics consultations play with respects to talking to stakeholders and trying to encourage people to talk from top down and make sure people are informed? Are there better ways of doing that? Now, I'm not sure I'm willing to take all of that on my own shoulders for an ethics consult every time there's an ED boarded patient, but I do think there may be some process issues to help in the communication so people can understand. The last thing I'll leave you guys with, and the thing that stuck out to me, was one of the most stressful parts of caring for someone who's ED boarded is not knowing when they're going to be discharged. They would say, if I knew they were going to be gone in a week, I wouldn't like it, but I'd be able to understand and manage that. The uncertainty every day on how long this is going to last was very, very burdensome.
I think too, it's sort of interesting. Like, this is kind of we're working on it in the care management department. It's a very social worky solution to the problem. Is like community building and how do we actually make that happen and make it meaningful. But there's kind of an interesting thing that I realized when I started spending time in the ED. It's like the relationships are different in an emergency department. And I actually think that is, there's a lot going there. We could probably unpack that for an hour, but there's a lot of aspects to strengthen that and kind of leaning into that. And so that's actually one of the things that I've been working on with my staff is like, how do we kind of support these really tight-knit relationships in a way that's really healthy and supportive? Because there's a lot there that you can really lean on your colleagues. It's one of those, like, I know it's true everywhere. It just feels like extra true in an emergency department, that, you know, people couldn't get through the day if they didn't have the people that they worked with.
My name is Laura Hosford. I'm the bioethicist for the Oregon Network for Peace Health. And one of the ethics consults that I get pretty frequently that causes me a lot of distress is pediatric psych patients boarding in the ED. And you heard what those conditions look like. And I will get safe to shares where people are putting in things to leadership and risk management saying, this is terrible. These conditions are inhumane, especially for children. And they don't understand why we don't at least admit them to the floor. And I was shocked when I learned that if you do that, then they're considered safe and placed, and they lose their position on the triage list for inpatient psychiatric treatment, and we don't have that in our hospital. We don't have that in our area at all. So I'm balancing that constantly where there's tremendous moral distress, and they're saying we can't keep this child here, and yet if we transfer them to the floor, they both don't get their care and they lose their place. And so it feels really, really terrible. But I do want to end on one hopeful thing, that Peace Health is planning on breaking ground very soon on a new inpatient psychiatric facility. I think like 150 beds, yes. And it will have space for adolescents, which is a huge, huge win for our community and gives me hope.
I mean, it's a great point. I think that, lots of times I'm trying to frame for people the difference between individual ethics and system ethics, right? The idea of what is happening to this individual patient, which is, I'm going to say, less than optimal. I prefer not inhumane, but it is a bad situation for sure. And framing things from their perspective about beneficence and non-maleficence and autonomy and all of those things that we would is not the place for these patients, right? Then on the flip side, you have allocation of limited resources, right? And system approaches in which, where does that patient need to be able to get to where they need to go? Or if this patient who doesn't have acute psychiatric problems takes a psychiatric bed, how long will they be there? Because this is a placement issue and they may be there for a month or two. And how many patients with acute psychiatric problems who needed the 7 to 10 day stay didn't have access? And what is the best decision in terms of the idea of allocation of resources? I'm not saying I like either of those choices, but I think sometimes that idea of boarding in the ED, and if people understood that a little bit better, not that it makes it better for the patient, or maybe makes it a little better for the staff to understand functionally why we have to do this. And it does put it into a different perspective. How helpful that is unclear.
Hi. It seems like you're preaching to the choir here. I'm wondering, I've never seen an article, say, in the Oregonian recently or someplace else where this issue is being addressed, as a public health emergency. So I'm wondering if is that something any of you are considering, or writing to the editor, really making the average Oregonian aware of it? You said 1 in 4 Oregonians come to the ED, 1.6 million visits, and most of them mental health and substance use related. So I'm just wondering whether that is something to consider. You talked about system level changes, and I think our speaker spoke about the culture of, ethic, culture. So that's a thought I've had while I'm hearing you speak. Any comment?
Yeah, the quick answer is no. I haven't thought about, although I can tell you that in the literature, there's very little written on specifically pediatric ED versus the adult world. Yeah, I'm gonna add that. Didn't you just hear the previous talk we had in terms of self-care? But I think this has, at least for myself, to get re-engaged in terms of institutional ethics. How are things getting back to the senior people, and what do they know, and what should they know, and how can that help get leverage with respect to at least taking a focus? And that might lend itself to talking to the media. That never stopped you, Lori.
But no, it doesn't stop me. But I wanted this panel to happen in part because there was a task force of the Oregon State Legislature that produced a report, I think that came out in November. That described the problem pretty thoroughly. Our lawyers at Kaiser think there will be legislation that will do things like speed up the process of getting Medicaid certifications so that we're not waiting 3 weeks for that just to be able to discharge someone. There are some potential legislative solutions for this, so this is a great time for advocacy because the Oregon State Legislature is very acutely aware of this issue, having just come up with a publication about it recently. Sorry.
No, don't be sorry. Thank you.
There is also, I'm on the case example was not PEDS-Psych, but PEDS-Psych is a lot of what happens in OHSU's ED as well. And I'm also on a pediatric behavioral health best practice committee that includes PEDS-Psych from all over. And there is Dr. Ajit Jetmalani is, I don't know, Susan, do you know? Working on legislation and advocating for it. So I think that's actually working its way through the legislative process now.
He is working on that.
Yeah.
Very actively. Nobody better than him.
Yeah, exactly.
Real quick, I'll go through this in my talk, but the Oregon recommendations, and then in January of 2025, there was a federal technical report as the result of a summit that was convened when 44, I believe, senators wrote in. And so they also have recommendations at the federal level. Where that will go, I don't know. It's very uncertain these days. When patients complain to me about waiting in the emergency department or waiting for their room I say, I'm so sorry, I wish it was different, you should write your political representative. And I mean that wholeheartedly, because I feel like this system has to change, right? This isn't, like we said, it's not an ED root cause. We need the psychiatric beds, the SNF beds, we need all of these things. And so I tell them, write your political person. Whoever that is, whoever you voted for, write them.
Hi, my name's Erin, and I'm a recovering emergency physician. Thank you. Anyone else in the room used to do emergency medicine and now doesn't? Part of the reason I left the field of medicine that I really loved for a long time is that the pressures that were created by this problem exceeded my design limits as an emergency physician, and they exceed all of the design limits of the people working there. Thank you for bringing this to such an important light in this conference. And my question is really a rhetorical one that probably doesn't have an answer, but the answer does not come from the emergency physicians and the staff who are trying to take care of these patients. We don't have the tools to do this, and the answer is not probably coming from the federal government. It comes from the people who are running the hospitals. So why has this not risen to the number 1 or 2 issue in every hospital administration?
So I'm just echoing what people have just said, and what Melissa just commented on was, we talk about how are we going to educate the public? What are we going to do about all of our staff in the ER? And then what about the patient that's in front of you? So I work on the hospitalist side, where by the time the patient actually gets there, they are so angry and they're so disgruntled that we actually have a hard time caring for them. So I appreciate your sort of talking to them about, like, I'm really sorry and you should write to your senator, but are there other ways that we can try to help the patient understand the expectations, and how can we help make the experience better, which I realize is sort of modeling what is our resilience, what can we help patients have better resilience so that they don't take it all out on us.
Can't resist, especially your comment. So, if you think about what's part of the core here is broken trust, because people have expectations when they come to the emergency room that certain things are going to happen. The people in the emergency room have expectations of what they think should happen as well. And so does the system itself. So in a number of ways, I think what we're talking about here is how do we begin to connect the sources of betrayal and broken trust, and how do we then restore in both the relationships but also in the structures. So our capacity for trust, we all come with our own experiences and our own capacity. If we're in a situation where we feel ineffective, where we feel that we are not able to do our job, our capacity for trust is already low. Now you're interacting with a patient whose capacity for trust has been completely dismantled, right? So it's the ingredients for conflict. So part of the answer to that is about communication. How do you recalibrate expectations in these circumstances for everybody? How do we understand the implicit and explicit promises that we've made, and when we fail to uphold them, how that contributes to this? And then the communication part. Are we transparent about the limitations? Are we able to explain the decisions in ways that people can understand? You know, those are some beginning things that need to happen all through the system to be able to really shift the experience in an important way. And part of it we do have within our control, but there's also other big parts of this that if they're not addressed at the systemic level, our efforts may inadvertently create more distrust. So.
Yeah, what she said.
I'd love to take a moment to just reflect, to share a reflection, because this conversation has been very distressing to me, and I've been trying to think about why. And frankly, so many of the things that you shared really resonated with things I've read in novels by Joseph Heller or Tim O'Brien, novels about the experience of being a soldier in war. And you think about people trying to operate in a system that, to borrow a military term, is full of malarkey, where there are real life and death consequences constantly at hand, where you constantly have to struggle with unknowns and lack of certainty about when stuff is going to go down. And maybe the one thing that sustains you is the camaraderie you feel. And I find it really distressing to think that the business of healthcare, the closest comparison I can have right now is the business of war. That really troubles me. I'm really lucky because in primary care, my patients are part of that camaraderie that I feel. And I don't know how we can recapture that in other healthcare settings, but the extent to which we can, I think would be something that would potentially help, right? Because we are here for them. So whatever we can do to help them feel like we are sharing this malarkey together and we're doing everything we can for you, and creating the right communications for that, maybe that would help. I don't know. I want to end on a more positive note than my distress, but I did want to share that reflection.
I mean, I think there is something like the work that's done in an emergency department is incredibly important. I mean, every day lives are saved. And I mean, the war analogy, there might actually be something there, and that's true. So I think that that's sort of really helpful to kind of highlight as much as there is all of these terrible things and all these borders. And I literally saw somebody's head getting sewed up, the middle of the hallway yesterday. But like ultimately, when it comes down to it, it's like the work that everybody does there is incredibly impactful for folks. So it's meaningful, even if it's challenging.
The way you frame that is really appropriate. I do think that there may be strategies with respects to trying to match people who may gain something differently from ED boarding. If there are people who have greater resilience or a greater appreciation for the bigger picture, could people be identified? Now, people are doing shift work and they're coming in, they're going, they're coming and going. I helped restructure things in a newborn intensive care unit for those patients who had BPD and were there for long, long periods of time. And how do you have people be able to frame and function differently than the rest of the patient population? Maybe there's something, I wanted to leave everyone with just a little hope. Maybe there's a way of framing that people could be identified, maybe even trained a little bit more to be able to find greater purpose, satisfaction in a less than desirable situation.
This doesn't fix the solution of ED boarding, but it's some positive changes that we've made. So on the theme of trying to end in a positive note. So we've started for years now an extended stay physician. So an ED physician that is not actively seeing acute ED patients and that is solely dedicated to our boarders. So during the day, they have time and space to dedicate to the boarders. And then the boarders are tried to be placed in a certain area of the ER where the nurses typically self-select for, their resiliency, their care or compassion to care for them. It is not a solution to ED boarding. It is helping to make it more compassionate in the emergency department. So just on a small positive note, we are trying. But again, like Erin said, the ED is not the fix, right? We are not the fix. We are looked to for the fix, but we are not the fix. But we can help maintain our compassion and help decrease our moral distress by doing small changes and feeling like we're doing something.
We are at time. Thank you, everyone. I think the speakers will be available for a few more minutes for any questions. Thank you.